Hi guys, we're going to talk about anger, aggression, and violence. And this is chapter 27 in your book, and I'm just going to get us started. So when we think about anger and aggression, anger is an emotional response to frustration of desires, threat to one's needs, either emotionally or physically, or a challenge. Aggression, on the other hand, is action or behavior that results in verbal or physical attack. Aggression tends to be used synonymously with violence. However, aggression is not always inappropriate and is sometimes necessary for self-protection. On the other hand, violence is an objectionable act that involves intentional use of force that results in or has potential to result in injury to another person. The CDC reports that 7 people die every hour in the United States from violence, so it's likely you will need to manage violent behavior at some point in your career. Nurses frequently are targets of violence because they have the most direct patient contact. Violence can occur anywhere in the hospital, but is most frequently in the emergency department. Very unpredictable. There's extra family members that are present, and situations can escalate pretty quickly. You also see them in psychiatric units. Patients tend to be more unstable mentally, but not all of them. So just making sure that if you enter into any of the units that you aren't necessarily in danger, just being more aware that there's a potential for problems. Other places are geriatric units and even the intensive care units. Some comorbidities that go along with anger and aggression include PTSD, substance abuse disorder. Nearly 11% of patients with bipolar 1 demonstrate aggressive behaviors. Anger and hostility are risk factors for chronic illness and may be predictive of hospitalizations for multiple chronic illnesses. So let's think about our risk factors. We can talk about biological factors, so genetic predisposition. Monoamino oxidase A gene is associated with anger and aggression, coupled with environmental factors may lead to a person having more violent tendencies. There are some evident factors in our biology that we can look at with the brain. We can see certain brain tumors, epilepsy, Alzheimer's, brain trauma, or traumatic brain injuries tend to cause more issues with anger and aggression. The prefrontal cortex of the frontal lobe does play an important role in aggression, and if we have damage to that area, we typically see anger and aggression that the patient may not have had before. Some are just more predisposed due to life events that lead them to more opportunity to anger and aggression. Neurotransmitters such as serotonin, dopamine, and gamma-aminobutyric acid, or GABA, play a role in anger and aggression. Cognitive factors. Early behaviorists believe that emotions, including anger, were learned responses to environmental stimuli. The stimuli is often a perceived threat, and this perception leads to the emotional and physiological arousal necessary to act, although the threat is usually understood as an alert to physical danger. Social learning. Researchers demonstrated that children learn aggression by observing and imitating behaviors of others, especially if that behavior is rewarded. Thus, children who watch television violence or experience violence in the home learn aggressive behaviors of resolving problems. So let's apply the nursing process to these patients. We know we always start our nursing process with assessment. When we are assessing someone that may have anger and is starting to show aggression, we do need to remember that it can manifest whenever we have increased demands on them. We see irritability, frowning, redness of the face, wringing of the hands, clenching their fists, are just some of those symptoms that we may see. Box 27.1 on 504 in your book states some other signs and symptoms that may be seen that precede violence, but these symptoms may not always be indicators. Hyperactivity, increased anxiety, verbal abuse, as well as other predictors are listed there. When we think about trauma-informed care, this is an older concept of providing care that has recently been reintroduced. It's based on the notion that disruptive patients often have histories that include violence and victimization. These traumatic histories can impede patients' ability to self-soothe, resulting in negative coping responses and creating a vulnerability to coercive interventions, things like restraints. Self-assessment is that last one there, and it's our ability to depend on our self-awareness in these situations. It can be very easy to become non-therapeutic in these aggressive situations if you tend to draw away when someone becomes aggressive. So what can you do? You can promote a calm response. Don't want to potentiate anger or start a yelling match with the patient or challenge them in any way during the situation. You really want to be in an environment that encourages staff to speak openly about their feelings, that can use humor when appropriate, and that displays that professional support system. After a thorough assessment and gathering of data, we can analyze our findings and what we want to focus on with our patients with anger and aggression. Many times anger and aggression results from ineffective coping or unhealthy coping. And you can again see signs and symptoms for these nursing analysis and those patient outcomes on table 27.1 and on page 505 in your book. Once we've assessed, we've analyzed, and now we're going to create goals for our patient and then we can intervene. When we start intervening, general interventions will be determined what the patient is feeling, acknowledging the patient's needs, and clearly stating the expectations for the patient's behavior. We can think about health teaching and health promotion, and that's going to really focus on coping mechanisms, de-escalation techniques, and self-soothing skills to manage those behaviors. Teamwork and safety is huge. It will be a multidisciplinary approach and being proactive versus reactive. There are 6 basic considerations for ensuring safety. 1, avoid wearing dangling earrings, necklaces, and scarves in an acute care environment. The patient may become focused on those and grab them, which could cause very serious injury. 2, we want to ensure that there is enough staff for backup. Only one person should talk to the patient, but staff need to maintain an unobtrusive presence in the case of the situation might escalate. The 3rd one is always know the layout of the area. Correct placement of furniture and elimination of obstacles or hazards are important to prevent injury if that patient requires physical interventions. Number 4, don't stand directly in front of the patient or in front of the doorway. The patient may consider this position as confrontational. It's better to stand off to the side and encourage that patient to have a seat. 5, if a patient's behavior begins to escalate, provide feedback. You seem to be very upset. Such an observation allows exploration of that patient's feelings, and it may lead to de-escalation of the situation. And then the last one is to avoid confrontation with the patient, either through verbal means or through a show of support with security guards. Verbal confrontation and discussion of the incident must occur when the patient is calm. A show of force by security may serve to escalate that patient's behavior. Security personnel are better kept in the background until they are needed for assistance. Despite every effort, patients may progress to violence and require seclusion or restraints. As nurses, we must approach the situation in a very organized manner. Seclusion is that involuntary confinement alone in a room that the patient is physically prevented from leaving. The goal of seclusion is never punitive. Rather, the goal of seclusion is safety of the patient and others. Seclusion is less restrictive than restraints and may be helpful in reducing sensory overstimulation. When we think about restraints, this is any manual method, physical or mechanical device, material or equipment that restricts freedom of movement. There are several contraindications for the use of seclusion and restraints. Patients who have extremely unstable medical and psychiatric conditions are not considered safe candidates for these treatments. Chronic obstructive pulmonary disease, or COPD, spinal injuries, seizure disorder, and pregnancies are also examples of contraindications for restraints. Delirium or dementia may make seclusion and restraint intolerable due to the absence of stimulation. These restrictive measures should be avoided in patients who are overtly suicidal and those who require monitoring for severe drug reaction or overdoses. Some of the guidelines for use of medical restraints include what is the indication for use. This is going to protect the patient from self-harm and prevent from assaulting others. Excuse me, what is the legal requirements? We have to document the behaviors before the use. We also should document the least restrictive attempt before. Clinical assessment, what is the patient's mental state at the time of the restraint? What was the need for the restraints? Observations, staff must be present constantly if your patient is in restraints. And then release procedure. When that patient can follow instructions and stay in control, they can be released. And some restraint tips that your book states is physical holding against the patient is a restraint. 4 side rails up is a restraint. Keeping patients in their room by physical intervention is seclusion. Tucking sheets in so tight that the patient cannot move is a restraint. Orders for restraints or seclusion cannot be ordered PRN. So what are some treatment modalities? We can think about pharmacotherapy. Anti-anxiety and antipsychotics are used with acute symptoms of anger and aggression. Benzos may reduce the amount of antipsychotic needed in order to control the agitation. SSRIs, lithium, anticonvulsants, benzos, and second-generation antipsychotics have all been successful with specific patients. And that concludes chapter 27. If you have any questions, you can shoot me an email or we'll chat about it in class. Thanks, guys.